Welcome to the Heart Failure Objections Handler Podcast, Episode 1. Ignite Recognition of the Need to Treat Elevated Heart Rate is presented to you by Marina and John from Egypt.
Hey everyone, welcome to our very first episode. I'm John, and right here with me is my co-host Marina.
Hi everyone, we are so excited to start this journey with you. For those who don't know us, June and I are medical reps, and we are here to give you an inside look at what we deal with every day.
Exactly, Marina. Being a medical rep is not a walk in the park. Each day, we face a lot of questions and objections from doctors about our products.
Absolutely. We are out there meeting doctors, talking about products like Procarlin, but it's not always a straightforward conversation.
Right, there is always a bit of resistance, and we get some challenging questions along the way.
And that's why we are here. In each episode, we are going to talk through those tough moments, share how we respond, and hopefully help clear up some of the common questions doctors have about Procarlin.
Thanks for joining us today. Let's dive in. All right, let's get into it. Here is one we hear a lot. With so many things to manage in heart failure patients, why is controlling heart rate such a big focus?
June, I had a case recently with one of the doctors. He was really concerned about heart failure patients that there are a lot of health parameters he needs to control. Why should he focus on heart rate?
I have heard that concern before. How did you address it?
I explained that he should really pay attention to this because heart rate plays a crucial role in heart failure and is equally important to all other health parameters. Heart failure with elevated heart rate carries a higher risk of mortality and hospitalization than that seen in heart failure patients with controlled heart rate. It has also been shown by epidemiological data that heart failure patients with an elevated heart rate face a higher mortality risk than patients with some type of cancer.
Moreover, in a recent meta-analysis from DAPA heart failure and DELIVER trials, it has been highlighted again that an elevated heart rate more than 70 beats per minute is responsible for a significant increase in risk of cardiovascular death by 61% and all-cause deaths by 48%.
That's exactly what I said. Doctors seemed more comfortable with the idea after we discussed how important it is to keep heart rate under control to prevent rehospitalization.
That's great. I had a situation with a doctor at public hospital. She was wondering increased heart rate might be a way to maintain sufficient cardiac output in patients with low stroke volume.
Oh, that's a tough one. How did you handle it?
I explained, whereas in normal conditions, myocardial forces increase as heart rate increase due to the positive force-frequency relationship. In heart failure conditions, this relationship becomes negative and a higher heart rate results in lower myocardial work. This is due to altered calcium handling and a cellular structure in failing heart cells.
Perfect, John. Furthermore, we could add that in heart failure conditions, increased heart rate is no longer a compensatory mechanism, and the higher heart rate can exacerbate symptoms by reducing ventricular filling time and increasing the oxygen demand, which worsens the cardiac efficiency. Thus, reducing heart rate with treatments like beta blockers and ivabradine improves stroke volume and the outcomes in heart failure patients.
I agree, Marina. And that's what I conveyed to the doctor. She acknowledged my point and asked whether there is a target heart rate to aim for in patients with chronic heart failure.
That's a good question, John. In fact, Shift was the first trial to identify the target heart rate for all heart failure patients, which is a heart rate of 50 to 60 beats per minute, at the heart rate achieved between 50 to 60 beats per minute after procarlin uptitration, resulted in a 50% lower number of subsequent cardiovascular outcomes compared with the patients who remained at a resting heart rate more than 75 beats per minute on treatment.
That sounds good, Marina.
Thanks, John. I faced a question that seemed basic but was actually quite important. The doctor asked when it's optimal to add procarlin to a patient's treatment.
Great question. I usually answer it like this. Procarlin should be initiated as early as possible for symptomatic heart failure patients with left ventricle ejection fraction inferior or equal to 35%. in sinus rhythm with a resting heart rate above or equal to 75 beats per minute as recommended by authorities in combination with standard therapy including beta blocker therapy or when beta blocker therapy is contraindicated or not tolerated.
I agree, John. This also gives us the chance to add that 2023 guidelines update recommended an early intensification of all guideline-directed medical therapies, GDMT, for heart failure patients to achieve the target doses. This is an opportunity to initiate procorilin earlier in the management of patients who still have an elevated heart rate despite these therapies at hospital discharge or at early follow-up visits to have better heart rate control without affecting any other hemodynamics, which could leave room for up titration of all other pillars needed.
You nailed it, Marina.
Thanks, John. You know, I had a bit of a different experience with another doctor during my visit yesterday. He asked if procorilin could be discontinued once the target heart rate is achieved to reduce pill burden.
I have definitely heard that before, Marina, and I responded by advising the doctor that I wouldn't recommend this approach, as ivabradine is eliminated with mean half-life of 2 hours in plasma and an effective half-life of 11 hours. It's therefore recommended to take the treatment twice daily to ensure proper effectiveness and appropriate heart rate control.
Perfect, John. And we can also include that once control is achieved, it's important to maintain all treatments to ensure that the patient continues to benefit from a reduced risk of cardiovascular events. In SHIFT, average heart rate at the end of follow-up was 67 beats per minute in the ivabradine group, compared with 75 beats per minute among patients in the placebo group who continued on background therapy, including beta blockers. Treatment should only be discontinued if heart rate remains persistently less than 50 beats per minute, despite dose reduction, or if the patient develops symptomatic bradycardia.
Exactly, Marina. I usually explain that if the doctor stopped prescribing ivabradine while his patient's heart rate is well controlled, he put his patients at risk of no longer having their heart rate controlled and of being at higher risk for the occurrence of cardiovascular outcomes. That wraps up today's episode. Thanks for tuning in, and we hope you found our discussion helpful.